And I know that is sciatica because it was right there in the middle of my back and I felt some of it on my butt.
Explain to me what you mean by that. Tell me in your own words what's going on rather than trying to label it.
Welcome to your daily health briefing. I'm Dr. Albert Tackett. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. One of my patients, let's call her Tiffany, walks in to see me and tells me that, Doc, I have this pain in my back. And it started on Saturday morning after I moved furniture around. And I know that is sciatica because it was right there in the middle of my back and I felt some of it on my butt. Mm-hmm. And I asked her, Tiffany, how do you know it's sciatica? She said, Doc, I just know because I looked it up on the internet. So instead of arguing with her, I said I will bring a pain management specialist to ask what is sciatica and how does it actually affect patients. So that's why I found the pain management doctor who's also called Tiffany to ask her. So Dr. Russ, what is sciatica?
Yeah, so the sciatic nerve is a specific nerve that runs, from our back, down our buttocks, down the side of the leg, all the way to the foot. And so sometimes when that nerve is irritated, and I say when nerves are irritated, you may experience electrical-like shooting pain, burning, tingling sensation, numbness, and even itching. But sciatic pain is a very specific pain. So every pain that runs from your back to your buttocks is not sciatic related pain, but that's okay.
So if we get into the science, what actually causes that electric shock? How does it work?
Yeah, so anytime nerves are irritated, that could be due to the disc kind of pushing back and pressing on the nerve. That could be due to arthritic joints becoming so inflamed that they're kind of encroaching or pressing on the nerves as they exit the spinal cord, if you will. It could be some sort of, injury, traumatic. I have a lot of patients who've had prior gunshot wounds and they have injury to the nerves as well.
And this is what patients would refer to as a pinched nerve.
Exactly. A pinched nerve usually refers to either the disc pressing on that nerve or joints themselves pressing on the nerve.
And because nerves carry electricity, so to speak, when they get pinched, the patient feels a shooting electric type of shock, pain.
Yes.
Okay. So why do patients refer to every pain in the back as sciatica? How did we get here?
I know. That's a good question. I think, everyone kind of uses that terminology really broadly. So for any type of pain. So I say, explain to me what you mean by that. Tell me in your own words what's going on rather than trying to label it. I have patients come to the office and they're saying, yeah, at my L4 and L5, it hurts. And I'm like, what does that mean to you? Just point to me on your body where it hurts and we'll kind of go from there. And then I always have a skeleton model and we'll kind of go over the anatomy so that they know and they're informed and can kind of use the correct terms to talk about how they're feeling.
So let's distinguish sciatica from all other types of back pain. How would we walk a patient to let them understand what is sciatica and what is a piriformis syndrome or a greater trochanteric bursitis or any one of these other pain syndromes?
Yeah, so it comes, back to kind of a basic understanding of anatomy. So first I say, hey, point to me where it hurts, and does it hurt more when you're doing certain things like bending forward to pick something up from the floor? That could be something called discogenic pain, or pain that's coming from the disc itself that supports and protects the bones. Or I say, does it hurt when you're leaning back or twisting and turning? That sort of pain could be coming from the joints that line your back, the facet joints. Or it could be coming, like you said, from the muscle itself. We all have a muscle that kind of overlies our buttocks and sometimes can press on that sciatic nerve as it exits from the spinal cord, and that's the piriformis muscle. So I say, does it hurt when you're doing this particular stretch or this particular movement or kind of sitting for prolonged times? So I think it's important for them to, again, point out where on their body does it hurt and what sorts of movements or specific activities trigger their pain. That helps me kind of pinpoint what is going on and then kind of address how we can help them moving forward.
Okay. So what are the actual treatments for sciatica?
First line of therapy is always physical therapy. No one wants to do it. They say, I did it in the past. It didn't work for me. And I say, guess what? We're going to do it again. Okay. You're going to really pay attention to those exercises and then kind of incorporate them from now on and forevermore. The next step is, anti-inflammatories, Tylenol, ibuprofen. And then a lot of my patients, of course, get injections because this is interventional pain management. Mm-hmm. So I offer them an epidural. And no, it has nothing to do with labor, right? An epidural is a way for me to give medicine, steroids, to help calm down that very irritated nerve that's causing that shooting like pain down your leg.
So let me tell you the next clinical problem we have here is that this same patient, after telling me it was sciatica, proceeded to say, can we do an MRI of my back? What is the issue with sciatica and an MRI? And should everyone with supposed sciatica get an MRI?
Not necessarily, because some people are going to respond with conservative measures. So doing physical therapy, taking Tylenol, taking ibuprofen, and maybe even taking an oral steroid course by mouth, okay? And the issue may kind of resolve itself, if you will. So we don't need to jump to kind of getting an MRI for every patient that comes in with pain that's now all of a sudden kind of shooting down their legs.
So who should get an MRI and when should we send the patient for an MRI?
Yeah, so first they should have an x-ray, right? Let's take a look at the bony structures and see what's going on first. And if these symptoms have persisted, right, despite Tylenol, despite ibuprofen, despite kind of taking an oral steroid course, despite doing physical therapy, then let's kind of go and see what else is happening in the background that's causing these persistent symptoms.
So as we wrap up, what are 2 things the patient should know about sciatica today to ease their concerns about that dreaded word?
Yeah, so know that it's something that we're able to treat. We have options, okay? All hope isn't lost. We're going to go through a stepwise approach with a specific plan that's tailored to you. Secondly, if it doesn't improve, know that there are still additional options, and the next steps may be talking to your primary care doctor to get a referral to an orthopedic surgeon.
Okay. And I will add another action item here for the patients. We first must establish that we are actually dealing with sciatica.
Absolutely, right? Every shooting pain is not sciatic nerve pain.
Fantastic. Thank you, Dr. Russ.
You're welcome.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Tacken, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.